Our next speaker is Sean Tunis. Sean is the founder and president and chief executive officer of the Center for Medical Technology Policy in Baltimore, Maryland. And the objective of the center is to improve the quality, relevance, and efficiency of clinical research by providing a neutral forum for collaboration among experts, stakeholders, and decision makers. He's a member of the Institute of Medicine's Committee on the Initial National Priorities for Comparative Effectiveness Research, and in a previous life, he was the Chief Medical Officer of the Centers for Medicare and Medicaid, where he had the lead responsibility for clinical policy for the Medicare and Medicaid programs in the U.S. Sean?
Great. So thanks, and I just want to be sure to say to Dave and Holger, I'm honored to be included on the program, and thinking back to my first actual opportunity to work with Dave and the colleagues at McMaster was when I was a fellow in general medicine at Johns Hopkins in 1989, and one of the other fellows that was sequestered into a small room along with three others was Rob Hayward, who was connected with many of the folks at McMaster. And so through Rob, we had the opportunity to work with Gord Guyot and Peter Tugwell and Brian Haynes and Dave and on some of these early users' guides. I don't remember which of Dave's careers that was, 4 or 5 perhaps. But in any case, what I just wanted to kind of point out that what I really learned from that experience, beyond just what a brilliant group of folks there were at McMaster and elsewhere in Canada, was just the willingness to work with junior trainees with not much experience as kind of equal colleagues, and in a way that was really reassuring to someone who was just kind of coming into the field. And I kind of carried that with me, I think, through my career of kind of recognizing how much can be accomplished if one really works in a kind of a egalitarian kind of approach. So, Dave, I want to thank you and your colleagues for that particularly. So, I noticed that I stuck the word sequestered into a sentence, and I'm not sure what's something about American politics has got that word stuck in my mind, but especially, I guess, today we're now, again, 2 days away from shutting down the U.S. government over some effort to repeal the Affordable Care Act, which I think is one of the most useful pieces of legislation in the last 50 years. But in any case, so you probably want to take insights from south of the border with a bit of a grain of salt. I think so far I'm the speaker from the furthest south. I think Susan is a little bit north of us. So in any case, I want to talk a little bit about some insights from some work that we're involved in, and to talk about pragmatic trials in a learning healthcare system. And this, a bunch of it is drawn from some work I've been doing over the past 12 to 18 months as part of the NIH Collaboratory. For those of you who don't know what it is, you will soon. So, going back to the theme of this conference of, is it, time to retire the randomized controlled trial, it sort of made me think of other things and people that are about 65 years old. I guess the the concept of retirement comes from the fact that the streptomycin trial was from 1948, and so we're 65 years later. So maybe, sorry, a step back. Disclosures. No. Well, I started off saying I had nothing to disclose, and each time I looked at this slide, I added something. So I have nothing to disclose except for the fact that we get some funding from NIH to work on the Collaboratory Coordinating Center, and then our center, our nonprofit, has a lot of unrestricted grants from health plans and life sciences companies, but nothing about products that are related to what I'm going to be talking about. So if RCTs were 60s rock stars, they would look like this about now. So that's a kind of a visual metaphor for, raising the question of maybe it is time to retire. Now, Mick Jagger actually is, I think, about 70 years old and a grandfather, and you might wonder about the appropriateness of, dancing around like he does. But, they managed to pull it off, and they managed to fill stadiums. So it makes you think, not unlike RCTs, that maybe there's something there of lasting significance, that it's not just nostalgia, it's real intrinsic musical genius and value. So I'm going to kind of return to this theme eventually, but in any case, I just thought it would be worthwhile looking at some other 65-year-olds. And then you have to kind of think about, well, if these folks retired, what have we got to work with? So some of the rising stars, you got big data here as a potential alternative rising star, and I don't know. Does anyone in the room know the name of that group? Go. Daft Punk. Okay. So hopefully some of you will have learned something here today. Then we have kind of mathematical modeling. This is another rising star. Presumably this is one of your own. That's right. That's. And then, of course, you've got the advanced observational methods. Unfortunately, I don't know, does anybody know where this picture actually came from, which event? It was the Video Music Awards, and unfortunately, this resulted in me having to ask my 11-year-old son what twerking meant. Now, probably, if anyone in the room doesn't know what twerking is, you should ask your kids, but... And I don't mean to imply that all advanced observational methods are, analogous to twerking. I'm not saying that, but some people might take that away from this. So anyway, the point is, there are some new methodologies coming along. They're nice to look at. They're potentially promising. Whether anybody will be paying attention in 5 years is hard to know, but we do know that people are still listening to the Rolling Stones. So my kind of the theme of my talk really is it's probably not yet time to retire the RCT, but I do want to say that I think there is a need to continue to reinvent it, and perhaps a desperate need to continue to reinvent the RCT, and that derives in part from what many people today and certainly in other contexts have pointed out as some of the limitations of, again, some but not all RCTs, that they're expensive, this critical problem of limited external validity or generalizability, the lengthy startup and enrollment times, and then, of course, the costly infrastructure that has to be created to conduct many RCTs, which is often not sustained after the trial is completed, meaning that sort of all the benefits of that investment are lost. And then perhaps the most significant issue is that the current approach just leaves too many gaps in evidence on important questions. And probably a lot of you have seen this, but this is from, the BMJ Clinical Evidence 2013, and, showing this is of 3,000 treatments that were reviewed, 50% were of unknown effectiveness based on randomized evidence. So you could look at that as a glass half full or a glass half empty kind of thing, but I would like to sort of definitively say that's a glass half empty. This is, in fact, it might even be a public health catastrophe, in the sense that means that 1,500 treatments are being used in some sufficient numbers to have made it into clinical evidence without any good evidence on whether in fact they're beneficial. And obviously, whatever the answer is, there are some people that are being harmed and some people that are being benefited, depending on what the clinicians are choosing to do. So I'd say, a working hypothesis here is that's a pretty strong argument for the need to be able to do much better in terms of generating the kind of evidence that's needed to help clinicians and patients and payers and other decision makers make decisions. So that's kind of the impetus and the introduction for the NIH Collaboratory program. And again, it's just been going for a year, so a lot of what I'm going to be talking about is potential as opposed to demonstrated output or progress. But I think it's setting out to solve a problem that's extremely important. So this is a 5-year initiative funded by the NIH Office of the Director. I think the total funding of the coordinating center and the 7 demonstration projects is on the order of $20 to $25 million. That's probably not precise, but it's on the right order of magnitude. And the aim of this is to expand the infrastructure for conducting highly efficient pragmatic trials through partnerships with healthcare delivery systems. Or, as folks could probably appreciate, the notion here is to try to use the architecture of the healthcare delivery system as a platform for conducting highly efficient trials, leveraging all of the resources that are already going into clinical care, data collection, electronic medical records, et cetera. So the intent, particularly of the coordinating center, is to develop tools, policies, and best practices that would allow the Collaboratory to rapidly scale up from 7 demonstration projects to the capacity for a large fraction of the healthcare system to be able to actually conduct simple pragmatic trials in the context of, integrated with the delivery of care. And the objective here obviously is, to try to seek an order of magnitude or more increase in the efficiency of being able to conduct randomized trials in real-world settings on important unanswered questions. And I think Salim had actually mentioned towards the end of his talk the need to find ways to exponentially increase the efficiency of generating evidence. And if we really believe that, as many of us do, that randomization is a critical aspect of being able to make fair comparisons on questions of efficacy, we need to find ways to conduct these studies at a much higher level of efficiency and output. So I won't go into this in detail, but it's just to sort of note that the concept of a learning healthcare system is really the same as the Collaboratory, which is to try to integrate the processes of providing clinical care with conducting research. And so the whole process of designing, implementing, and evaluating new practices is fully integrated with the actual delivery of care, but on specific identified questions introducing randomization. One of the things that we've been talking about several times today, and I'll come back to it briefly at least, related to the concept of the learning healthcare system, is that under the current human subjects paradigm, it fundamentally assumes that research and care are different. And the learning healthcare system assumes that research and care are integrated. And we don't actually have a human subjects paradigm that allows for that. So somewhere, if this is actually going to become a reality, there's a lot of work to do in terms of rethinking that. So you're not going to care a lot after today about the organization of the Collaboratory, but this is what the Coordinating Center looks like. And just to mention, Rob Califf from Duke is the PI, Rich Platt from Harvard is the co-investigator of the Coordinating Center. And then there's a whole bunch of individual working groups that are trying to solve challenges and problems and technical and methodologic issues that apply to all of the demonstration projects. So working groups on electronic health records, PROs, the regulatory and ethical issues. We actually, our center is in charge of the stakeholder engagement piece, which is basically bringing all of the non-healthcare system or non-research players in the healthcare systems to the table to kind of help address some of these broader cross-cutting challenges. So again, what the Collaboratory is doing through this coordinating center and the demonstration projects, it's funded a number of trials that have to be pragmatic by design. They use electronic health records as the core data collection instrument. So all of the studies that qualified as demonstration projects had to have a primary outcome that could be collected through the electronic health record. They had to involve at least 2 integrated health systems willing to collaborate to address the question. And again, there were 7 projects funded. And just to give you a feeling for what at least one of the projects looks like, this is a study, one of the demonstrations that's called the TIME trial, so time to reduce mortality in end-stage renal disease with the PI at the University of Pennsylvania. And the primary goal of this study is evaluate the effects on mortality, hospitalization, quality of life of an extended duration of thrice-weekly hemodialysis. So basically this is looking at the question of whether a longer duration of hemodialysis is more effective than the standard duration of hemodialysis. It's a study of 5,100 patients starting hemodialysis at participating facilities. And the study is being done at 322 dialysis facilities, all of which belong to one of these large mega dialysis chains. So it's a 322 facility study. It's going to be a cluster randomized study, but the fairly large cluster because there's 322 facilities are involved. The data sources, as I said, electronic health records that are already in use at the dialysis provider, so that's where the main outcomes primary outcomes are going to come from, except for they're going to need to collect quality of life information directly from patients. I'm giving you sort of an estimate here, but the total expected budget for this study of 5,100 patients is expected to be somewhere between $3 and $4 million. So obviously, they are expecting huge efficiencies from the fact that all of the clinical care is being provided anyway, and most of the data is being collected anyway, and so what's being introduced here is simply the cluster randomization to allow for comparison. So I think this is a reasonably good illustration of at least what this collaboratory organization is aiming for. And I won't go into much detail about this study, but another one of the studies is basically a comparison of morning versus nighttime dosing of antihypertensive medication, looking at adverse cardiovascular events as the study endpoints, and it'll be an 1,100 patient study, also with a similar budget of $3 to $4 million. So here's what I would call progress to date with the Collaboratory. I do think that it's an important model, and there's been a promising start towards substantially increasing the capacity and the efficiency of conducting randomized trials by integrating it with the delivery of care. Some of the major challenges that have been identified so far is probably first and foremost is the issues around the need for individual informed consent and the potential increase, reduction in the time to be able to enroll these studies, and the cost of doing these studies. So it's pretty clear, and Rob Califf says this every time he talks about this program, it can't possibly succeed unless we make headway on these human subjects issues. And then the second thing, which I think folks are less focused on, but it's clear that it's a big issue for me, is that the business case for healthcare systems, integrated delivery systems, to become partners in research is not at all clear. It's really clear why researchers like to partner with healthcare systems. It's not at all clear why healthcare systems would want to partner, or what's the benefit to collaborate with researchers. And until we actually figure out that there's a genuine business case, this thing can't possibly succeed. But I do think that the potential here of addressing some of the major limitations of randomized trials in terms of not being conducted in real-world settings, with kind of typical patients and treated by typical providers, and all the issues about the expense and the time and the inefficiency, all of those could be potentially addressed. I guess a question that we would have to raise, amongst many others, is whether the approach of doing pragmatic trials in real-world settings can actually produce the kind of fair comparisons that we're looking for. A lot of these studies don't have blinding, and some of the other things that Dave started out as talking about as critical to being able to make, fair comparisons of efficacy. But, we'll go back to our friends, the Rolling Stones, who said, you can't always get what you want, but if you try sometime, you just might find you get what you need. And so I think, who knew that the Rolling Stones would have a comment to make on methodology and clinical research? But I think they pretty much captured it as, are we going to get what we need? So thanks, and I'll look forward to the discussion.